Hi, everybody. Welcome back to our fourth segment of Coffee with Clinicians. I am here with the esteemed Dr. Charles Andersen. He is the Director of Wound Care at Madigan Army Center. He's got a background in vascular surgery. Dr. Andersen, what am I missing here?
Now, let me elaborate a little bit on that. So I'm very, very fortunate to work at Madigan Army Medical Center, where I have been for many, many years. We have a very unique clinic there. It's our limb preservation clinic. So in one clinic, we have a combination of advanced wound care, advanced podiatric surgery. We have two full-time limb preservation podiatrists. And then we have a full staff of vascular surgeons and a vascular lab, all co-located. So we co-manage many patients that are at risk for amputation. Our wound care clinic is also the wound care clinic for the hospital. My position, I manage both the outpatient wound care clinic, where I see clinic 5 days a week, and then I oversee the inpatient wound care. So that affords me the opportunity, both through our limb preservation clinic, as well as the wound care clinic, to see some very challenging wounds. So it's in that setting that I've had the opportunity to use EO2.
That's wonderful. And I have been blessed to come and see you at that center about a year ago on one of your patients. And I have known of you for a long time through a previous work experience. And so when you are one of the few clinicians who uses our therapy regularly, when you see a wound, what triggers you to think to put oxygen therapy on that?
Based on the literature, but also based on the experience that we've had up to date with the device. As suggested in Dr. Lavery's paper, the larger and the more chronic wounds are the wounds, interestingly enough, that seem to respond to the therapy when other things have failed. There's another factor that I believe plays a role, and that I think is borne out at least by some of our clinical experience, and that is the wounds that I refer to as a focal ischemia or regional ischemia associated with that wound. So many times you see a wound that's been present for a long time. There's a lot of scarring around that wound. And despite debridement, there's very little activity in that wound. Or it's a wound that's had a radiation, or it's a wound that has associated vascular insufficiency. Those, I think, set the stage for an ischemic or regional ischemia of that wound. So we look for wounds that have failed other therapy, larger wounds, wounds that appear to have that appearance of a regional ischemia.
Awesome. And then, and you've had some pretty good outcomes. I've seen some of your patients' testimonials online as well. And that's always good to see from a clinician's perspective, that they're pleased with the choices that you've made, and that they are getting good outcomes as a result. And knowing that if you were to come before CMS, the body that gives us the golden ticket for reimbursement, what would be your plea to ask them to cover this therapy?
I think in an individual anecdotal experience, I think it's good to talk about. And oftentimes we make decisions in our clinic based on our experience. But when you're trying to get approval, I think what's required is controlled data. And I think that this therapy has very good science, but it also has the literature supporting this therapy. So I think to point out the outcomes, the control, so the control in the library study, for example, was a very tight and a control that I think anybody would have trouble arguing with. But what that demonstrated was that these wounds heal more rapidly. And these are difficult wounds. In general, you're not using this device on a wound that you expect to heal in a timely fashion. This therapy in general is used for those wounds that have failed other therapy that are very chronic, and you're looking for something that will heal these very difficult wounds. And for presenting that case, I would look at the literature and present the literature, which is very, very strong.
And that's actually why I came to this company. I was very impressed with the clinical literature and evidence supporting the use of the therapy, because I didn't want to put my name, and of course you don't either, behind something that you don't believe in, and that isn't proven in a scientific background. What is the most notable difference that you see in your own patients there in Washington?
Some of the wounds that we've used this therapy on have been very, very challenging wounds. Let me give you a couple of clinical examples. One is a patient that had had irradiation for lymphoma, had ongoing chemotherapy, and had a lesion on her back in an irradiated field. Mm. This wound had been present for well over a year. Nothing had really even shown any response in treating this wound. And it was a very painful wound for the patient. So when we initiated this therapy, we saw two things. Number one, for the first time, we started to see this wound start to be active and form margins of cellular activity around the wound and in the wound. And the other big thing that we saw in this patient, which was obviously very, very important to the patient, is a decrease in the pain associated with this wound. We've also seen that another case is a lady that had a very difficult spine reconstruction, had a chronic wound, had underlying hardware. So there was a feeling that she might have a chronic osteomyelitis, or at least some biofilm in the hardware. Very, very painful wound. And again, initiating this therapy not only closed that wound, but I can tell you what was really important to this patient and what she emphasized the minute she walked in the clinic is, I just want to thank you. I'm not having pain anymore. So
wow.
This is the kind of things that have been remarkable for us. Seeing those wounds that other therapies are just not showing any progress, but also the wounds that have been very painful to the patients. And you get that dual benefit, the benefit of not only seeing these wounds progress, but also the benefit of modulating or even totally relieving the pain that's associated with these difficult wounds.
And I know as a clinician, that just makes you feel good that you've given them a piece of their life back. Dealing with that chronic pain is on a day-to-day basis is difficult to do.
Absolutely.
How simple is this therapy compared to some of the other devices that you use? I know you use a lot of advanced modalities. How easy is this for you, your clinicians, and the patients to use?
Actually, it's very simple. And once you're familiar with how the device works and you educate the patient, which doesn't take very long at all, basically it's like they're carrying a cell phone around that's connected to a little tube that goes into a dressing that's very, very easy to apply. It's basically a dressing that fits on the wound. There's self-adherent dressings, but there's also dressings that we put tape around. But basically it's like putting any other fairly simple dressing on, tape around it, turn on the machine, and The patient goes home with this little device, knows that they have to charge the device, and knows how to troubleshoot. But the nice thing is, this is unlike, let's use, for example, negative pressure wound therapy, where, it's very important that you have an airtight seal. And if you have foam in a wound and you lose that seal, then that can become colonized. This is in and of itself a good dressing to put on the wound, even if you didn't have the oxygen. So if for some reason, the oxygen is off, uh, it isn't like that patient has to take that dressing off within a short period of time or go to the emergency room.
Mhm.
They can just come into the clinic, and if there's something wrong, we can fix that and reinitiate the oxygen therapy. So to answer your question, lots of words there, but it's a simple device to use.
And what kind of research, we talked a little bit about the literature that's out there, and there is a meta-analysis coming. What kind of research would you like to see in the future with this device?
I think, like any of our advanced wound care products, I think once you get to the point that you know that they work, then you can get down to the more of the science of what's really going on in the wound, and that can allow you to make changes that may actually improve an already good device. So I think more research on exactly what's going on at the cellular level. Although there is some good basic research, I think more basic research. There are several devices available that provide a type of cutaneous oxygen. I
Mhm.
think those devices differ, and one thing that clinicians have to do is they have to make a choice of you know among those or between those uh, cutaneous oxygen devices. I personally think there's a difference in the devices, and I think eventually to understand the difference and where different devices may play a different role. This
Mhm.
is a unique device in that it's truly right at the wound level, providing a high level of oxygen tension right through the dressing. So it's unique, but I think research looking at different devices that are available and how the different devices may vary.
Well, I thank you so much, Dr. Anderson, for your time and for um, your continued efforts using and helping us with this therapy and getting it to the soldiers who truly deserve it after all that they've done. I am a military family girl, so I really appreciate what those men and women do for us. And so my hat's off to you, and I appreciate you taking coffee time with me tonight. And I look forward to more discussions.
Well, thank you. And I must say that, you know, we work with many different companies, but the support that EO2 provides and knowing that you're working with a group of people that likewise really believe in the device, as well as the clinicians that are using it really believe in the device. It's easy to talk about something in that framework. So thank you very much.
Thank you.